Right, coming on automatically. Excellent. Okay, thank you very much. Thank you very much, Chairperson. Thank you to Professor Rajapaksa and the Council for inviting me to give this talk. A pleasure. Might be slightly alarmed to know that the person who was meant to give this talk was the person who supervised my PhD. Never a good start, is it? So I am the stand-in, but a more official stand-in. So respected teachers, ladies and gentlemen, been thinking about what I might say as an intensive care doctor looking after patients who have acid-base derangement, as the chairperson alluded to, on a regular basis. I'm sure you all have a system of interpreting and understanding acid-base balance, and I think my role would be not to give you another system or try to give you another approach to looking at that. So I kind of thought maybe I'll start with a couple of messages which resonate in my mind when I look after unwell patients, and maybe focus on a couple of things which are nuanced in terms of understanding acidemia and how that might help with clinical management. So the first thing I'd like to say is a little plea. So as an intensivist or intensive care doctor, quite often you get a bit of number voyeurism. People pick up the phone and they want to tell you that they've got this patient with this number. It's usually either a pH or, as the colleague from previously alluded, some sodium. They want you to be impressed by a number that there is a pH of 7.1 or we've got this patient. It's much more important to understand why and what the patient is than the individual number you're being told. And that leads a lot to misunderstanding and over-treatment. And I think you saw some examples of how the sodium, which was probably a problem and was symptomatic by its derangement, was then worsened by the treatment provided. And you see a lot of that in terms of acid-base balance. So that's kind of one plea. And second, directly leading from that, is to try and think when you see an acid-base derangement, how is this affecting the patient? Because, okay, the number is abnormal, we recognize that. But how is that affecting the patient? The reason I say that also is people commonly think acid-base balance is very tightly regulated by the body. I would like to suggest that's a little bit of a myth. Because if you have a pH of 7.4, the way the logarithmic scale is set up, that gives you a hydrogen ion concentration of about 40 nanomoles per liter. When the pH is 7.2, I don't know whether it will surprise you if I tell you the hydrogen ion concentration is now 64 nanomoles per liter. So in fact, the hydrogen ion concentration has changed by more than 50%. And this is not an unusual patient in the hospital. I suggest if you took blood gases from your patient you see on a day-to-day basis, this is not unusual. It's certainly not unusual in the patient population I deal with. So perhaps the pH or the hydrogen ion concentration is not that tightly regulated. And that directly leads to my first point about try to understand how this alteration in hydrogen ion concentration is actually impacting the patient. So for example, a person with COPD who has a pH of 7 is very different from a person with diabetic ketoacidosis who has a pH of 7. And I think that's really important, and perhaps you might see that theme as we try and discuss a couple of examples. So the theme I decided to try and touch on during this little talk is maybe an anion gap. And I thought maybe that's a good thing to highlight and maybe provide a little approach to how you might interpret changes in the anion gap and how you might anticipate and understand compensation in terms of an anion gap, and how that as clinicians, that might give you a little more information to treat this patient. So I thought maybe I'll work through a couple of examples, maybe a third one. Just trying to see that this comes up. So in this patient, if I told you these are kind of the numbers, I'll let you have a little look at those numbers. So this patient is obviously quite unwell, not dissimilar to the patient who gets referred when you work in an intensive care unit, pretty unwell. And a common question, is there an anion gap? You might ask, how is that important? Maybe I'll try and highlight that in a moment. So what is an anion gap? The anion gap is talking about the difference between measured cations and measured anions. Just looking to see, the screen doesn't come up here. Oh, sorry, it's me being blind. Thank you. So it does show the difference between the measured cations and the measured anions, and there is a component of measured anion, unmeasured anions, which contribute to this anion gap. Predominantly, it is the proteins and the sulfate. Now, another important thing when we understand that is that there is a compensation required to interpret the anion gap if the proteins are low, because a lot of the anion gap is contributed by these proteins. If the albumin is low, for every 10 grams of albumin below the normal level, you do need to make an allowance for the anion gap of 2.5 milliequivalents. Now, you might think that's not so common in patients, but in the critically unwell patients, you will not be surprised to think that's quite common. You see this albumin derangement quite often, and as we know, that doesn't always correlate with survival. So if the anion gap is high and the pH is low, then this patient does have a metabolic acidemia. And I thought maybe I'll focus on that and try and illustrate a couple of examples which show how that varies in these patients and how the anion gap might inform your interpretation. So if the anion gap is high, there is a metabolic acidemia with a low pH, and the bicarbonate is not low. Because if you go back to this equation, if the bicarbonate is not low and the anion gap is high with the metabolic acidemia, it does mean there is another disorder present. And going to the strong ion difference, which I'm not going to try and describe, it includes derangements in chloride are likely. And touching on the previous speaker's comments, it might be because we have resuscitated someone with lots of chloride, which is now causing a hyperchloremic acidemia, again, which you will be able to detect by looking at the anion gap in this way. So if that is the case, may I then propose a slight advance? You might want to look at the anion gap in relation to the bicarbonate. So how has the bicarbonate changed in relation to the change in the anion gap? So that's a delta anion gap divided by delta bicarbonate. So how this helps us is, if this change, if the bicarbonate change doesn't directly tally the anion gap change, it alerts us that there is something else going on. And maybe I will use a couple of examples to highlight that. And you can see if the ratio is 1, you can be fairly confident that this is a high anion gap acidosis, and what you're seeing is probably representative. The bicarb is representative of the problem, and you will be able to interpret that relatively easily and be confident that there is no second disorder, no second metabolic disorder, to be precise. However, if the ratio is not 1:1, then perhaps there is another metabolic disorder going on in this metabolic acidemia. Why do I say that? Perhaps you'll see. Maybe this is a medical school acronym, mud piles, again, just an acronym to try and illustrate the causes of a high anion gap acidemia. quite often asked in examinations, and a kind of a good acronym to work your way through once you spot that somebody has a metabolic acidemia with a high anion gap. And that includes things like cyanide. So going back to our example of the gentleman we were discussing, so this patient does have an anion gap which increased. It is 18. If we consider 12 as the normal for the upper normal limit for anion gap for this calculation and example, we can say there is a derangement, and if we do the delta anion gap divided by the delta bicarbonate, if we take the lower level of the bicarbonate as 24, then you can see that the ratio is 1:1. So I'm not going to touch on the osmolar gap. I don't want to confuse and make this more complicated, so I'll pass that for the moment. But if I just work through this, I'm sure you all appreciate there is an acidemia, and it's now pretty obvious there is a metabolic acidemia. So is there any compensation? Again, I'm sure you all have your own way of working that particular bit out. But I think it's sufficient to say if the direction of the CO2 is in the opposite direction to benefit the acidemia, then there is compensation. So in this case, I think you can see there is respiratory compensation. And I want to touch, maybe you can also try and predict the extent of compensation. Now, this kind of number helps me interpret a blood gas, because it helps me understand that for every CO2 coming down by 1.2, so if there is a metabolic acidosis and there is a reduction of bicarbonate by a millimole, that will be followed by a CO2 reduction of 1.2 millimeters mercury. That's the kind of compensation you are expecting. So if you're looking at a blood gas, and in this patient we saw the bicarbonate had changed by 6 millimoles, then you're expecting a change in CO2 of about 8 millimoles. I don't know whether that makes sense. So if you now look at that patient, it does suggest there is a compensation. It is a respiratory compensation. And if we look at the ratio, we can be fairly confident that this is just an anion gap acidemia. So if I'm just going to go through, skip the AA gradient, not to make this any further complicated. But if we now think what the diagnosis may be, I hope it will not come as a surprise to you that this person has a high anion gap metabolic acidosis with some respiratory compensation, and there is a high lactate, and that's causing the acid-base disturbance. If I move on to another example to maybe show a slightly different nuance to what I have now illustrated. So this patient is an asthmatic patient who's presented to emergency, has been using an inhaler quite often. The asthma has been getting worse and is now in hospital. So again, some blood gas results for you to consider with an oxygen-inspired oxygen concentration. So this patient does have an AA gradient, an alveolar arteriolar gradient. Like I said, I'm not going to go into that, but perhaps you'll concentrate on the acid-base disturbance and think about those numbers we discussed and how you might go about interpreting that in your own mind. So as I work through that, again, is there an anion gap in this patient? Yes, there is. And the anion gap is 17. So going back to our concept of can we try and see whether the bicarbonate is following this change in anion gap, you can see the change in anion gap is 5, but the bicarbonate change is only 3. And therefore, we should be wary that there is perhaps a metabolic process in addition to what we are seeing. I pass through the osmolar gap again. So just trying to work through this. Is there an acidemia? Yes, there is. Is the primary derangement respiratory or metabolic? Again, I hope it won't come as a surprise to you, given the extent of the pH derangement and given the extent of the CO2 being high. This is obviously a respiratory acidemia at its source, and given the history correlating to what we have heard of the patient. Again, I hope it will also be not a surprise to you that this patient is very unwell, an asthmatic patient with this kind of CO2 causing this kind of acidemia is very unwell, and you would say that this is near life-threatening asthma, if not already requiring very, very urgent intervention. So is there compensation? So going back to our previous calculations, if we kind of think of the numbers, is there compensation? Going back to our equation of expected compensation, if there is an acute respiratory acidosis, we expect the bicarb to go up by 1 millimole for every 10 millimeters mercury. This is the other way around to what we discussed earlier. So we want the bicarb to have gone up, but in this patient, you can see the bicarbonate is actually lower than normal. So does that mean there is no compensation? No, it doesn't mean that. It means there is a compensation, because if you go back to our conversation about the anion gap, it suggests there is a metabolic acidemia. And if we went back and looked at the ratio, we expected the bicarbonate to have reduced by at least 5 in relation to the anion gap acidemia. However, it hasn't. And in fact, the bicarbonate is only 3 lower than what you would expect. So in this patient, what you're having is an additional metabolic process. So again, I hope it will not come as a surprise to you in an asthmatic patient who's breathing very fast and very hard. There is a strong element of hypovolemia, and you see these in these patients. So the metabolic, the acidemia you're seeing may be mixed and is quite often mixed. How is that important? When you try and intervene with this patient, whether that is an intubation or whether that is trying to rescue, some people might try something like non-invasive ventilation. I suspect the patient we are discussing is beyond that stage. But if you were to try and intervene, you have to understand the metabolic derangement you are seeing may be more than the respiratory element. And I think this is a very good example to interrogate the numbers you're seeing a bit further. So if the CO2 being high is not reflected in the bicarbonate change in relation to the anion gap, it alerts us to think that there is perhaps a metabolic element going on despite the compensatory efforts. I realize that's a little tricky to convey in a talk like this. I understand it's a little tricky, but I hope that alerts you in your mind when you try to interpret derangement in acid-base balance, to consider the anion gap and to consider whether the bicarbonate has followed the change in the anion gap. And if it hasn't followed that change, perhaps be alert, there might be another process going on, whether that causes an increased anion gap acidemia or a non-increased anion gap acidemia. I hope that conveys a little bit. I do understand it's a little tricky to convey this kind of thing in a talk like this, so apologies for trying. So just going back, is there another disorder present? Yes, there is, and the other disorder is metabolic. And quite often, what is this disorder? In this patient, I just rushed through that a little bit. As I said, you get increased work of breathing, you get anaerobic metabolism, and you get a significant element of hypovolemia. And when you intubate these patients or you try to treat them, they are far more unstable than they appear. And that's very important in the risk stratification and management of these patients. And quite often people who haven't recognized this metabolic derangement are the people who walk into that unanticipated challenge. So perhaps that's helpful in understanding that. So this patient does have an acute respiratory acidosis. There is an element of compensation because the bicarbonate is not as low as it should be, and there is a metabolic acidemia going on with that. So I'll move on with that. Time's coming up. So just to summarize, so I wanted to try and highlight a couple of things. Firstly, to say acid-base disturbance must be viewed in context of the patient. What do I mean by that? Is to try and understand how is this acidemia, which is the predominant problem people worry about in hospital when they see an acid-base disturbance, how is that affecting this patient? What is the danger we are anticipating, and what is the evidence that danger is coming to pass? And how are we going to manage that? It then forces you to think, what is causing that acidemia? You then have the decision tree, is that high anion gap acidemia or is it a normal anion gap acidemia? If it is a high anion gap acidemia, is the bicarbonate following the derangement you are seeing in that anion gap change? If it is not following that, then perhaps there is another metabolic process, and that is probably the take-home message for this morning from me. Thank you very much for your attention.
Thank you, Rashan, for your excellent talk. Now we can take a few questions, and it's open for questions.